Hi, everybody. Welcome to today's webinar on the clinical application of the methylation pathway, where we will be learning about the effects of one-carbon metabolism on chronic disease. We are excited to have Dr. Michael Chapman speaking for us today. My name is Christine Stube. I am a medical education specialist at Genova's Asheville branch, and I'm going to be moderating today's webinar. So I'll be collecting all of your questions to ask at the end of the webinar. Dr. Michael Chapman is a licensed naturopathic physician who graduated from Bastyr University in Seattle, Washington in 2012. Upon graduation, he spent 3 years in private practice specializing in women's hormones and gastrointestinal conditions. Dr. Chapman then joined Genova Diagnostics in 2015 as a medical educator, and he's currently the product development manager and a product line specialist for nutrition, hormones, and genomics at Genova. Over the last 3 years, he has delivered multiple presentations at the American Academy of Anti-Aging Medicine and Institute for Functional Medicine events. Prior to naturopathic school, Dr. Chapman earned his Bachelor of Science degree from Indiana University with a focus in neuropsychology. He later worked as a microbiologist performing pharmaceutical research on cancer cell lines. And Dr. Chapman has a passion for learning and helping others come to a greater understanding of the vast and dynamic processes that exist and interact within the human body. We're happy to welcome you today, Dr. Chapman, and you can take it away from here.
Great, thank you, Christine. Can you hear me okay?
I sure can.
Great. And thank you everyone for being here and taking time out of your busy schedules to learn a little bit about methylation. I always feel like methylation is an exciting topic these days and something that a lot of us are focusing on and thinking about with our patients. So thanks for being here, and we'll kind of get right into it. Some learning objectives for today's presentation to discuss the clinical impact of methylation imbalance. I think we're starting to learn more and more about this concept of methylation. And one of the things that I often hear is, how do I translate some of these things that we know into actual clinical utility and clinical outcomes? So, I think that's one of the major learning objectives for today. We'll also review important details of the methylation and the transsulfuration cycles. We'll get into that. We'll talk about some of the genetic SNPs that are related to methylation and discuss different ways to test and assess methylation, as then at the end, essentially, what do we do clinically to address any sort of methylation dysfunction or concerns that we're seeing in our testing. So taking a step back and thinking about the big picture and the big question, in general, what is methylation? This word gets thrown around quite a bit, and it's good to actually understand even what we're talking about. And methylation at its core is just a biochemical reaction. It's a transfer of a single carbon from one molecule to a different molecule. It's kind of like a game of biochemical hot potato is one way I like to think about it. And that's why methylation is also referred to as one-carbon metabolism in the literature, because it all revolves around this single carbon unit. And so you can see this molecule, S-adenosylmethionine, which is also known as SAM, or SAMe when we use it as a supplement, but it has this extra methyl group. And what it does is it passes this methyl group on to different molecules throughout the body. So as an example, we have 4-hydroxyestradiol, and if you're familiar with estrogen metabolism, this is one of our estrogen metabolites that is thought to be more associated with increased hormone-mediated cancer risk. This can turn into what's called 3,4-quinones that can cause DNA damage. So we always want to neutralize this 4-hydroxyestradiol. And SAM is involved in doing that. It passes its carbon to this metabolite to turn it into 4-methoxyestradiol. And that's phase 2 detoxification. And what this accomplishes is it neutralizes that 4-hydroxyestradiol and allows it to be excreted and removed. And then that leaves the product S-adenosyl homocysteine, which is essentially that SAM molecule without its carbon group. And this is the basis of methylation, and this is what it looks like. It's not just restricted to neutralizing hormones. Methylation is also used in things like creatine production out of arginine, and that's involved in skeletal muscle energy production. It's also involved in creating our neurotransmitters like epinephrine, as well as disposing many of our neurotransmitters. So just give you a few more examples of what that looks like. And if you're familiar with biochemistry, you might be saying to yourself, well, this looks like every other reaction in the body. So what makes this particular enzymatic reaction special? And I would say, it's really not. It is like every other biochemical reaction in the body. But what is special is how often the body uses the methylation reaction. And so one thing I like to say is, if you want to know how important a single process is to the system, just look at how often that process is used. And it really ultimately comes down to all the different systems that depend on methylation. So for example, I mentioned creatine production for skeletal muscle contraction, DNA and RNA synthesis, epigenetic gene regulation, hormone regulation and detoxification, energy production, cell membrane repair, lipid metabolism, neurotransmitter production, nitric oxide production. So you can see there's a lot of systems that utilize this methylation reaction. And that's the thing that makes it so important to the body, and why we need to understand it and get a grasp on it. And if we kind of look where this fits into the whole system of patient care, here we're talking about methylation in the bottom left quadrant of this circle. It's something that we can find and analyze and test, and it'll show up as a functional disturbance. And by correcting these types of functional disturbances like methylation abnormality, hopefully we will address symptom manifestation or even prevent it. And as you can see, that functional disturbance also is very, very much dependent on a patient's overall lifestyle, their nutritional habits, and even some things like toxic exposure and hormones that can impact these biochemical pathways as well. So then, what are some of the patient populations that I might be thinking about with a methylation assessment, or just questioning, are they having adequate methylation in their body? Bioidentical hormone replacement, I think, is a major area where I would be thinking methylation first and foremost, because as we saw before, estrogen detoxification and hormone modulation detoxification is accomplished through methylation. So we really want to make sure that that is transpiring very efficiently, so that hormones we might be prescribing are being detoxified appropriately. But that's not just limited to hormones either. Alcohol is detoxified through methylation reactions, toxic exposures like mercury and arsenic as well. And then the next area in our research that really talks a lot about methylation is cardiovascular disease and cancer. Certainly family histories around cardiovascular disease and cancer risk would pique my interest, or known cardiovascular disease or cancer would be another area I might be thinking about. Mood disorder and psychiatric diseases have a lot of literature around their associations with poor methylation status, particularly things like anxiety and depression. And that makes sense given what we know about how methylation is involved in the production and regulation of neurotransmitters. But also things like neurologic diseases and cognitive decline have some pretty strong literature around methylation abnormalities. Chronic fatigue, we saw that creatine was dependent on methylation for energy for the muscles. So that's another thing I might be thinking about. Some good literature from Jill James and some other individuals around autism, ADD, ADHD, this sort of the spectrum disorders and methylation impairments, as well as impairments in glutathione production, which we'll get into a little bit today. And lastly, can't forget prenatal care. One of the first areas that we got started with this idea of methylation and methylfolate came from our prenatal vitamins, right? So we certainly don't want to leave that out. And then one of the things that I was thinking about was, at its core, methylation is about cellular health, maintaining DNA, making glutathione to reduce free radical damage. And so I started looking at the literature and saying, well, what if we actually broaden the scope of this concept of methylation and just look at overall aging process? And there it was right in the literature. Methylation alterations have been associated with the aging process and the increased incidence of diseases as we age. So essentially, all age-related diseases have a methylation component likely at its core. And you can see here from this article, especially nutrition-based decisions, including intake of essential nutrients, involved in the metabolism of methyl groups, are believed to be factors in delaying the progressive deterioration of DNA methylation patterns. So as such, continuous maintenance of proper methylation might be important for healthy aging and may slow the development of age-related pathologies. So I think that's a pretty impactful statement that was made in this article, and really gets to the core of why understanding, assessing, and treating methylation abnormalities is so important. And when I think about trying to explain and relate this methylation concept, I think it's good to take a step back and first really get that framework as far as what we're discussing. And I think if you're like me, you might find beauty in a picture like this, or if you're also like me, you might find beauty in a picture like this. And if not, then don't worry, we're going to kind of walk through this a little bit, and you will feel a lot more comfortable at the end of this presentation. So the methylation cycle, just to give you some quick facts, this is happening billions of times every second in every cell in the body. So just to impress upon how much the system really relies on methylation, it's happening all the time. It's completely dependent on key nutrients like amino acids, vitamin cofactors, minerals, essential nutrients like choline and betaine, and it's strongly regulated by our hormones as well as environmental toxins. Uh, One of the major hormones I think about that has an impact on methylation would be our glucocorticoids and even things like corticosteroids. So the amount of stress that we're under can have a major impact on this. And of course, many common genetic variations, what we also refer to as SNPs, affect how efficiently it works. So let's get right into it. First key takeaway is that the methylation cycle is really about making sure there's adequate SAM, or S-adenosyl methionine. I refer to this molecule as SAM as compared to SAMe. When I say SAMe, I'm talking about the supplement. So that's the way that I kind of try to keep these things separated in my hand. Even though it's the same molecule, if I'm talking about supplementation, I tend to talk about SAMe, whereas if I'm talking about measuring this, I talk about SAM. And methylation is really about making sure there's adequate SAM. SAM is overwhelmingly the body's main methyl donor. So every single methylation reaction in the body pretty much uses SAM as the cofactor. So because of that, I tend to think of SAM as kind of like the body's methylation currency. It's like your methylation cash. So then SAM donates this methyl group, kind of like we saw before with that estrogen metabolite. It donates a methyl group wherever the body is trying to use it, wherever we need an extra methyl group. And that ultimately leaves SAW, this S-adenosyl homocysteine. And SAW then breaks down into a molecule we're probably a little bit more familiar with, homocysteine. And we'll talk a little bit about that. But with this kind of cash on hand analogy, what I tend to think of is if you start running low on cash, or in this, as an example, if you start running low on SAM, this methyl donor, what do? You have to start budgeting, right? You have to say, okay, well, I'm running low on SAM, I'm running low on cash. Where am I going to budget? Where am I going to pull back some of these methylation reactions? Maybe it's around detoxifying various environmental toxins. Maybe you're not doing that as efficiently. Maybe you're not making as much energy for your muscles. So you can start to see immediately if you have SAM deficits, you're going to start having to limit some of these critical processes in the body, which is not a good thing, right? So ultimately, we want to make sure we're recycling SAM as efficiently as possible. With respect to homocysteine, we just mentioned it. Homocysteine, you may know, is a marker for cardiovascular risk, and elevated levels are associated with atherosclerosis, coronary artery disease, osteopenia, neurodegenerative conditions, mood disorder, and things like IBD and colon cancer risk as well. And when I hear that list, what I start to think of is, wow, those start to sound not just like cardiovascular risk concerns, but those are absolutely things that are associated with methylation abnormality, right? So I tend to think of homocysteine even more as a biomarker for methylation. And a lot of clinicians use homocysteine that way. They'll often aim for optimal homocysteine levels somewhere between 2 and 10 is what I often hear, with some adjustments. Some people like to keep it even a little bit lower than that. But the key takeaway again here, homocysteine has to be recycled back up to methionine and then even back to SAM to ultimately get that cash back. And high homocysteine is very, very problematic to the system. The reason is homocysteine significantly impairs how we are able to remove SAW. So the conversion between homocysteine and that previous marker, SAW, can go back and forth. And it actually tends to favor SAW production. So this means that homocysteine actually really creates a major backup in this whole cycle because it then impacts SAW. It tends to lead to high SAW levels. So I think another key takeaway is if you have a higher homocysteine, you're likely going to have a higher SAW. And why does that matter? Well, the literature is indicating that plasma SAW levels may actually be a more sensitive indicator for cardiovascular disease and methylation abnormalities. So all this time, we're talking about homocysteine, but it might be that SAW is a greater marker, a more sensitive biomarker of cardiovascular disease than homocysteine, and suggests that SAW is a critical pathological factor in homocysteine-associated disorders. That's why elevated SAW is problematic. It's starting to look that SAW is likely a better marker for methylation dysfunction and the associated clinical conditions, right? And so all this time we've been measuring homocysteine when we actually are probably indirectly measuring SAW. So the next question is probably, well, why haven't we been measuring SAW? One of the reasons is that plasma concentrations of SAW are very, very tiny. They're about 1/500th that of homocysteine. So we need specialized technology to really accurately measure SAM and SAW. It requires very sensitive equipment to be able to detect it accurately. And thankfully, with the advance of modern technology, more labs are developing the capacity to measure things like SAM and SAW. So then once you have SAM and SAW, then you can start to do some interesting types of analyses. We know SAM is our body's main methyl donor, and we know that SAW is a marker for methylation abnormality and poor recycling. So in the literature, you'll see a lot of this SAM-SAW ratio, just kind of a comparison. Do you have more cash or do you have more debt, so to speak, when you're thinking about SAW? This is also called the methylation index in the literature, and a lot of times is associated with the overall capacity in the cell to perform methylation reactions. Also has been shown to correlate with the amount of DNA methylation. So, this is a great marker to be looking at when you're trying to get an overall sense of how well the cells are actually are able to methylate. One of the problems with the SAM-SAW ratio is that it tends to be pretty tightly regulated, right? If the cell is running low on SAM or has high SAW, then it's going to really start creating some problems. It's not going to be making DNA as well. It's going to be making epigenetic changes. It's going to have a hard time detoxifying. So the body really likes to control this SAM-SAW ratio as much as possible. And the other thing is that in general, SAM tends to be under even more strict control. So fluctuations in the SAM-SAW ratio at the end of the day are probably strictly due to the SAW concentration. It's really about how much of that SAW is around that's impacting and mudding up the waters. So then just finishing this cycle, homocysteine must be converted back up to the top. It has to get back to methionine and then to SAM to kind of start the process all over again. And this requires 3 key nutrients: folate, particularly activated folate in the form of 5-methyltetrahydrofolate. B12, again, activated B12, because as you can see, this B12 can kind of go around and get oxidized. And when it's oxidized, it's actually not usable. And we'll talk a little bit more about that later. And then one of the things that we tend to forget about, actually, zinc is a critical cofactor in the methylation or remethylation of homocysteine back up to methionine. So since we have gone around that basic methylation cycle, let's do a little bit of a case. We have a 75-year-old female, longstanding pernicious anemia, standard American diet, some coffee, processed meals, nightly wine intake, and some symptoms such as depression, anxiety, osteopenia, fatigue, osteoarthritis. So what are the trouble spots right away that we're seeing off of just the intake? Well, probably some concerns around dietary folate intake, given what she reported in her diet history. We also know that alcohol intake can deplete things like folate and B12. She also reported pernicious anemia, so we have additional concerns around her B12. And then finally, whether she's getting adequate zinc in her diet is I think something worth questioning, as well as the coffee consumption, which we know can deplete some of our minerals. So what does Beth's methylation results look like? SAW and homocysteine are elevated. So as we said, we're probably seeing some problems around remethylation back up to this methionine and SAM. But her SAM, when we looked at it, actually seemed to be okay. And we mentioned that SAM tends to be under pretty tight control, right? The body doesn't want to run out of cash. So the SAM-SAW ratio even doesn't look too bad. And you might be wondering, well, how is that? If we're running low on 5-methyltetrahydrofolate, zinc, B12, she's got high homocysteine and SAW, how is it that she's still making adequate SAM? Well, here's where a backup pathway comes involved. So we'll walk through this a little bit. There exists a separate sort of an alternate route to get homocysteine back up to methionine and SAM. And this is by using the molecule betaine, or trimethylglycine. Betaine can be used to turn homocysteine back into methionine. Now, this only takes place in the liver. And why is that important? Well, the main pathway, that big blue circle, that happens in just about every single cell. But this backup pathway only happens in the liver. So it's almost like the body has to kind of do extra work. It has to ship the materials off to the liver to run this backup pathway. So it certainly doesn't seem that this is the preferred way to do things. Betaine as a cofactor is derived from dietary choline, from things like meat, eggs, and beets. And one of the concerns about using this backup pathway is that because betaine comes from choline in our diet, choline is not just used for this. Choline is not just a byproduct or a cofactor for methylation. Choline is used a lot in the body. It makes acetylcholine. It's used for cell membrane repair. It's used for maintaining our myelin in our nervous cells. So we don't want to be shunting choline away from all these other pathways just to serve the purpose of methylation. I think that's one of the concerns about using this backup pathway. Now, we are looking at betaine and choline as biomarkers nowadays. As mentioned, choline and betaine are ammonia compounds. They come from our diet. Choline can be made, but it's just getting it in your diet alone is not enough. Or I'm sorry, you can make it in your body, but you also need to get it from your diet. And choline deficiency is a big concern because, as we mentioned, choline is used for, at the bottom left, you can see gene regulation, precursor to our lipoproteins. It's used in phospholipid and cell membrane repair. It's used to make acetylcholine. And this is as compared to betaine, which is pretty much only used for methylation. Okay, so you don't want to constantly be turning choline into betaine because you're going to be shunting it away from some of these other important processes. And as biomarkers in and of themselves, they seem to have some pretty interesting clinical associations and clinical utility. Choline is a major lipotroph, meaning it's used to make things like VLDL. And plasma choline levels are actually positively associated with things like triglycerides, glucose, BMI, body fat, waist circumference. So an elevated plasma choline it might be something a bit of a problem to look out for, as compared to plasma betaine, which is actually negatively associated with all of those things. So in general, we'd like to see a higher plasma betaine and a lower plasma choline. And here's another article demonstrating just that a low betaine, high choline is a risk. And actually, when you look at the ratio at the bottom left, this is associated with serum ALT, lower HDL levels, higher LDL levels, higher cholesterol, and serum glucose as well. So, there's a lot of interesting literature coming out on this betaine to choline ratio. And getting back to how it fits into the methylation pathway as this backup, here's a really, really interesting study. What they did in this study was they looked at rural African women that have a particular diet, and they looked at them over the course of a year. And one of the interesting things about this culture is that they have a wet season and a dry season in their diet, and the diet components are hugely different depending on those different seasons. Whereas in one season, they have a much higher meat intake with heavy in fat and protein as compared to the rest of the year where they're eating a lot more carbohydrates. And this translates to the amount of dietary folate that they're getting as compared to dietary fat and protein, which is going to be high in things like betaine. And what they found was that this backup pathway competes and alternates with the main pathway just dependent on need. So it's kind of like these two pathways are doing a bit of a dance. And if you have lower folate intake, then the backup pathway will work harder, and vice versa. If you have a higher folate intake, then the backup pathway will slow down, which is kind of cool. And really, it tells me that these two things are working in concert with each other. And it's about balance. It's making sure we're getting all the nutrients that we can. And I do have the concern when there are individuals who are vegan, because obviously we already talk about vitamin B12 and that being a concern with low animal protein intake. But we also know that betaine is very, very high in beets. So if I am talking with a vegan and working with their methylation, I would be making sure that they are getting adequate beets to help with this backup pathway. Another concept that we talk about a lot is over-methylation. And I think the big question around over-methylation is it a thing? We talk a lot about it, and we have signs and symptoms that are associated with over-methylation on the left-hand side: anxiety, depression, panic attacks. The truth is, if you look in the literature and try to find over-methylation as a clinical concept, it won't be there. There is no literature that's really discussing over-methylation as a thing. Maybe concerns around taking too much folate, you might find some literature articles about that. But when it comes to that translating to over-methylation, it's not there. Now, I don't think that means it's not a thing. We certainly have a lot of clinicians, and a lot of our empirical evidence suggests that there are individuals who have a hard time tolerating high levels of methyl B12, methylfolate. So I think this is going to be an area that we will study a lot more in the future. But it does also make sense biochemically that high levels of SAM could be having an effect on neurotransmitter metabolism, maybe even creating more byproducts like DMG and sarcosine that we'll get into that could have their own action in the body as well. So I think with respect to over-methylation, we'll be hearing more and more about that. And if you're looking to test for over-methylation, what would you look for? First, low homocysteine would be one thing that's discussed and has been discussed with over-methylation, although the truth is we don't often see low homocysteine in the body. It's pretty rare that I will see that on a lab test. However, a high SAM-SAW ratio would certainly be one thing I would be looking out for, and if I were to see a high SAM-SAW ratio come back, I might be thinking about over-methylation and evaluating somebody's nutritional supplementation. And then what are some things that clinicians often do to prevent or reduce over-methylation as a concern? Vitamin B3 is really popular for this, and the thought there being vitamin B3 will help SAW transition to homocysteine such that it can turn into other byproducts and be removed from the cell. So that's one of the main reasons that B3 is considered. I think glycine would be certainly another thing I would be looking at if I saw a high SAM-SAW ratio and I was concerned that maybe somebody has been on a lot of methylation support. Why? Well, glycine is actually used in a very important process, which is a disposal chute, essentially. If the body has too much SAM, then it will get rid of it in a way that doesn't, say, over-methylate genes or make too many products. It's kind of like a safety valve where it can dispose of this excess SAM, but it requires glycine. And glycine is something that we often test on our labs as well, and sometimes we will find coming back on the low side. Part of the thought around why that might be is glycine is used in a lot of different things. It's used in glutathione production. It's used as a neurotransmitter. So looking at glycine levels in conjunction with this topic of over-methylation, I think is very important. And clinically, glycine tends to be a great therapeutic aid, especially for people who have anxiety or difficulty sleeping, because it tends to be a central nervous system, overall inhibitor as compared to things like glutamate, which can excite. So this is a nice therapeutic just to help in general. And it tastes good too, actually. So that's another nice benefit of glycine. And then lastly, for over-methylation, vitamin B6 would be certainly another thing I would be thinking about, because the enzyme CBS needs vitamin B6 to remove homocysteine from the cell. We'll get into that a little bit more, but those would be the three main things I would be thinking clinically if I would like to address an over-methylation concern. Many articles have reported that higher levels of SAM are associated with a high BMI, a high protein intake, and high caloric intake. So here we are looking and we're saying that SAM is what we want. SAM is the main methyl donor. It's our methylation currency. But yet articles are starting to suggest that high SAM levels are seen with obesity and high caloric intake, high BMI, which is kind of interesting because when you think about that, my question became, well, is metabolic syndrome actually an over-methylation disorder? And lo and behold, there actually is some evidence to suggest that DNA hypermethylation is associated with type 2 diabetes. So there might be down the road a sort of greater understanding that overmethylation is in fact a thing, and it could be what is underlying some of our metabolic syndrome issues. So now that you're all experts on the methylation pathway, let's add just a little bit more to this picture. We talked about how CBS requires this vitamin B6, and at the bottom of this graphic, homocysteine can come back around and be remethylated up to methionine through either this main pathway, which requires folate and vitamin B12, or a backup pathway that now we know requires betaine. But the other thing that homocysteine is important for is in this pathway called transsulfuration. And why do we care about transsulfuration? Well, one reason is if you look at the bottom right, a major product of transsulfuration is glutathione. Glutathione, as you may know, can be given in a supplement, but the reason why you would do that is that it's one of the body's most powerful antioxidants. And so glutathione, to a certain extent, ultimately depends on the availability of homocysteine. The transsulfuration pathway also makes pyruvate, which is on the left-hand side, the bottom left, and taurine, which can be used by the cell to make energy. So not only does homocysteine come down and turn into glutathione for antioxidant support, but it also can turn into energy. And one key takeaway of how these things all fit together is that transsulfuration is upregulated by two factors. High SAM levels is a huge thing that will turn on the CBS enzyme, resulting in an increase of transsulfuration, meaning homocysteine will come down and turn into either glutathione or pyruvate and taurine. So SAM is critical in doing that. The other thing that will cause these metabolites to shift down into the transsulfuration pathway is oxidative stress. And that makes sense, right? Because if the body's under a lot of oxidative stress, it's going to say, hey, we need more glutathione. We need more of these antioxidants to protect us. And indeed, it'll start making more based on oxidative stress. So keep in mind that SAM availability, SAM is our main methyl donor, this determines the rate that homocysteine goes down into the transsulfuration pathway. And the translation there is that glutathione production will not take priority over creating SAM, right? So we first need to make sure we have adequate SAM for methylation reactions. And then if there's enough, we will then make more glutathione and vice versa, right? So if there's a low SAM level, then that's going to mean there's a low glutathione level because that whole transsulfuration pathway will slow down. So when we see low glutathione, we don't normally think of that as actually potentially being a methylation problem, but it is because SAM controls how much glutathione we're producing, which is pretty interesting. And you know, when you start thinking about glutathione as a biomarker for methylation, it really kind of opens your eyes a little bit. So then, of course, we can't talk about methylation without getting into the methylation genomics, right? How did we get through so many slides already without mentioning this MTHFR, which is a lot of what we think about when we think about methylation. But just to take one step back, single nucleotide polymorphisms in and of themselves are very, very common. I can't impress upon that fact enough. Most of us have millions of SNPs actually, and they're not causing any impact to our regular day-to-day lives. They are probably working in harmony to counteract each other. And so SNPs are something that are important to look at. I think they provide a lot of clinical utility, but they're also very common. And genes are not our destiny, right? If you have a particular SNP, that does not necessarily mean that you are destined to have methylation dysfunction. It might put you at more risk, but there are certainly things that can be done in the diet, in the lifestyle to help alter or lessen the impact of genetic variants, genetic SNPs. At the end of the day, SNPs alter the activity of an enzyme. They will either upregulate an enzyme, they'll either downregulate, or actually probably in most of the millions that we have, they don't really have much of an effect. But the ones that we tend to look at clinically are ones that alter the activity of the enzyme, making that enzyme work either faster or slower. And again, genes do not make your destiny. I try to make sure that my patients are aware of that the clinicians I work with are aware that, you know, just because a patient comes back with genetic polymorphisms, it does not mean that they need to be on a methylfolate for the rest of their lives, right? That being said, let's start with MTHFR, methylene tetrahydrofolate reductase, one of the most common SNPs that we are aware of as it relates to methylation. And MTHFR is right here. This is involved in taking dietary folate, which usually dumps into this form of THF. And MTHFR essentially activates it. It adds a methyl group to turn it into 5-MTHF, or I should say it doesn't actively add a methyl group, but it's involved in activating this folate so that it can be used by the body. And there's two SNPs that we tend to look at. There's A1298C, and this A1298C tends to not be as much of an impact on the SNP as the other one, C677T. But these can both result in slowing down this MTHFR enzyme, which ultimately leads to a risk of not producing enough of the 5-MTHF, or a tendency to have lower conversion into that active form. So one thing clinicians can do if they're concerned about that is give 5-MTHF as a supplement, and indeed a lot of people do that. Now I tend to, before giving a supplement just based on someone's genes, I will look and say, is there evidence of methylation dysfunction? Is there a high homocysteine or a high SAW? Is there low SAM levels, right? So we want to compare the genes with the actual biomarkers. COMT is another methyltransferase. This is tested fairly commonly. And getting back to the beginning, this is the enzyme that actually is involved in the detoxification of estrogens. But it also is involved in other things as well, degradation of catecholamines like epinephrine, norepinephrine, and dopamine. And here, SNPs in the COMT enzyme result in a slower enzyme as well. So you might have a slower detoxification of estrogens, a slower degradation of adrenaline, which could result in things like anxiety, perhaps. And one thing to know is that the majority of us actually have one SNP in COMT. So then one of the bigger questions kind of becomes, well, if you have no SNPs, does that mean that the enzyme is actually working faster than average? I've had that question posed to me several times, which I think it's an interesting question. A few more SNPs you might not be as familiar with. MTR, which is methionine synthase, this is kind of the guy that's responsible for the whole thing. This is the one that actually turns homocysteine back into methionine using folate, B12, and zinc. And SNPs in this enzyme actually result in a faster MTR action, which sounds like it would be a good thing, right? It sounds like it would lower homocysteine and SAW levels. But one problem is that it could be stripping folates away from this folate cycle. Now, we're not going to talk about the folate cycle very much today. That's probably a topic for a totally different webinar. But folate is not just used for methylation. It is used for a lot of other things, including nucleotide synthesis. So if you're actually committing folate to this methylation cycle, you could be stripping folate away from these other important aspects, which is, I think, that hypothesized mechanism for why this SNP results in things like cleft lip, spina bifida. Not in all individuals, of course, but there's an association in the literature. MTRR is a SNP that results in the downregulation of an enzyme that its main role is in recycling vitamin B12. As we mentioned, vitamin B12 can become oxidized where it's then not usable. And so we need this MTRR enzyme to reactivate, revitalize vitamin B12 so it can be used again. And people who have SNPs have a predisposition towards this enzyme working slower, meaning it's not going to keep recycling vitamin B12 enough to keep up. And there is, in fact, a lot of literature around SNPs in this enzyme, including various cancers, mood disorders, birth defects. And if you were to see it, you might think about just supplementing directly with methylcobalamin. Or you could think about betaine and choline to make sure the backup pathway is actually assisted, right? CBS we hear quite a bit about. There's some debate in the literature around the CBS SNP and whether it results in an upregulation or a downregulation of this enzyme. Most of the literature I have seen with the C699T is that it can result in an upregulation of the enzyme. So essentially, more homocysteine is brought down into this transsulfuration pathway, which may in fact be a preventative thing, might be a good thing because it could lead to higher glutathione production. But then I think the converse question is, well, will it actually steal some of the metabolites away from the methylation cycle, and do these people need more methylation support? We're still learning more, and there's some conflicting literature around this particular SNP, although it does seem to have some clinical associations. And just briefly, a few others that we'll be looking at. We have MAT1A, which is actually the enzyme that turns methionine into SAM. And SNPs here result in a slow enzyme, meaning a likelihood or a predisposition to having less SAM being produced overall, which is could be problematic. GNMT, which results in an upregulation of this disposal pathway. Right? So if that's happening at a more rapid pace, we could be seeing higher SAW levels, lower SAM levels. And then lastly, this backup pathway is through the enzyme BHMT. And there are SNPs in this BHMT enzyme, which results in a faster enzyme, which has been associated with more positive clinical outcomes, lower homocysteines, lower SAWs, and actually things like lower cardiovascular disease risk. So this actually might be a SNP that's somewhat favorable. So then how do we test for methylation? How do we know whether methylation dysfunction is happening in our patients? There's a few things to look at. DNA methylation is one way to test where we're actually looking directly at the genes and how much they are methylated versus unmethylated and what that means for gene expression. Trouble is, this is currently for research use only and is only really specific to DNA. It doesn't tell us about whether estrogen is being detoxified well. It doesn't tell us about whether neurotransmitters are being affected. And the other thing to note is that the plasma markers, such as the Sam-Cell ratio, have actually been shown to correlate with DNA methylation. So it might actually be a fairly decent surrogate to look at the plasma biomarkers like the Sam-Cell ratio when we're concerned about DNA methylation. Another thing that's very common is genomic profiling. There are a lot of companies out there doing just a whole litany of genetic testing. And, I think one of the main complaints I hear about this is clinicians will, or patients will come into the clinician's office with a whole list of thousands of SNPs or hundreds of SNPs. And it's difficult to speak to because there are so many different things on those reports. And a majority of these SNPs are either really, really rare or don't alter the enzymes that much. So, it can be a concern where a patient comes in with all these, red looking SNPs and they're freaking out. And the truth is they may not be having any impact at all. So it can be difficult to know which SNPs are truly actionable. So what we are doing is trying to create a combined assessment, right? Let's learn from systems biology to put this report together. So we created a genotypic and a phenotypic evaluation of methylation. So let's lay the genes and the SNPs on top of the biomarkers. That way we can say there may or may not be a predisposition and it may or may not be impacting. So this is one way that we're looking at methylation as a little bit of a bigger picture, and we're using novel biomarkers that can give us some broader insights into changes in the methylation pathway, and we'll talk a little bit about that. But again, we're doing genetic testing and biomarker testing on the same report. The report kind of looks like this. There's 3 pillars at the top. On the first pillar, this is a methylation pillar where you might be finding biomarkers related to poor methylation, like higher homocysteine, SOL, lower SAM, things of that nature, as compared to the transsulfuration pillar on the right-hand side, which, as we discussed, relates to antioxidant production like glutathione and may indicate needs for antioxidant support. We're also looking at 10 genomic SNPs. One of the things that we try to keep in mind when we're determining whether a SNP is worth evaluating is how prevalent is it, right? It's not very helpful to be testing a SNP that occurs in 0.0001% of the population. You're never going to see that in clinical practice. So how frequently is this going to actually occur? What does it mean clinically? Does it have clinical associations and can it cause actual true problems to manifest? Is another factor we use to determine whether we should put it on the report. And then lastly, is there something we can do about it? Is there some sort of clinical intervention that might help this SNP not be as much of a clinical impact? And so with that, we've got these 10 SNPs here, most of which we discussed already, but we also tried to categorize so you can know which one of the positive results will show up or result in a faster working enzyme or a slower working enzyme. So we tried to categorize so that it becomes pretty simple and clear there. At the bottom of this first page, we have these ratios. The first one is the Sam-Cell ratio, which we discussed earlier, also called the methylation index. Then there's this methyl balance ratio, which is actually pretty interesting. What we tried to do was say, because we know the Sam-Cell ratio is pretty static in its control, the body tends to keep this pretty homeostatically controlled. Can we find alterations earlier before it results in a Sam-Cell ratio change? And so we did that by comparing 4 biomarkers that have an extra methyl group to give. We compare it to 4 biomarkers that have had a methyl group removed. So it's kind of like the idea of the Sam-Cell ratio, but we just expanded it. So now we're including SAM, methionine, betaine, and serine that all have an extra methyl group compared to unmethylated metabolites. So We're assessing the buffers and the backup systems to see if the body has shifted and we can detect it earlier. This is a completely novel biomarker, and we are currently doing some literature around it, but it actually was able to very clearly distinguish a healthy cohort from an unqualified unhealthy cohort. So a lot of interesting things coming out with that particular biomarker. And then the last ratio on this first page is a similar concept, but we wanted to look and see, is this system top heavy or bottom heavy? Because ultimately, like we discussed, there's the methylation pathway and the transsulfuration pathway. So can we compare these two main pathways to see, is there a shift in the ability to make glutathione and the products downstream, and how can we affect that? So just a quick summary on those. There's the SAM-SAW ratio, where we might see more severe alterations of methylation abnormality, the methyl balance ratio, which is meant to be an early indicator of methylation dysfunction, and then the MET-sulf ratio, which looks at the balance between methylation and transsulfuration, which might indicate needs for B6, magnesium, and antioxidant support. We have 14 biomarkers on this particular test, and they're separated based on some of the concepts that we talked about, like whether they have a methyl group or not, and the transsulfuration metabolites. And the other thing that we tried to do was, since we're doing a genetic test on top of a biomarker analysis, let's put it all together. Let's put it all on one page so that you can see the patient's genetics as well as their abnormal biomarkers. So you can say, okay, they've got a SNP here, and it is or is not resulting in a true backup. Is it causing a problem or not? And that way you can start to see this entire pathway in real time with the patient. And that just allows you to visualize the delicate balance of abnormalities in the pathway. So ultimately, we're translating this pathway into a real-time patient result that you can see. And then lastly, for each SNP that we're testing, we're providing a complete commentary page for that particular SNP. I think that will be helpful, especially for the ones that are a little bit newer, including MTHFR. But really the thing here is that the patient results are at the top left. They tell you whether that patient's results will result in a risk towards upregulation or downregulation. More details that we actually get quite a lot of questions around, what's the RS number for the SNP, or what are the amino acids that it codes for? So sometimes we get those questions. So we are providing that up front for transparency, and then all the information, what does it mean for me clinically? And lastly, just a few minutes on some things to think about in treating methylation. The first one is methylation products, right? If we see imbalances in methylation, we might be thinking about, first and foremost, our green leafy vegetables, of course, but do we use folate, or do we use 5-methyl tetrahydrofolate is one thought. Do we use activated B12 versus hydroxycamolamin, which we'll sometimes hear about. Betaine and zinc are all things we think about from a methylation support standpoint. Transsulfuration, we'd be thinking more about some things like vitamin B6 and glutathione antioxidant support. Just briefly about folate, we have a lot of conversation out there around folate and which is the best form. Most of the research coming out discusses folic acid, because that is the molecule that is used all over the place. But there's lots of debate about folic acid, and it certainly has been discussed as far as how available is it. Does it turn into these things called unmetabolized folic acids, or UMFAs? And there is some literature that it may have interactions with some of the receptors, but there's so far I've not seen a lot around clinical outcomes that demonstrated folic acid being a problem. That being said, I do think it makes sense that things like folinic acid, it could be a better form to use, because it may not have the same impact. And then ultimately, 5-methyl tetrahydrofolate, 5-MTHF, is the active form of folate. My only concern is, could that irreversibly be committing extra methyl groups to the methylation cycle? And is that a potential for over-methylation? We're actually doing some literature studies on that right now with this new test that we put out. So stay tuned on that. And then vitamin B12, of course, a very common deficiency among the elderly, and as well as vegetarian vegan diets that are not getting animal sources of vitamin B12. Methylcobalamin is the active form as compared to cyanocobalamin, which is synthetic and must be converted. One thing about vitamin B12 is that serum B12 measurements may not really give you the whole story around vitamin B12 functional levels, and that's why the organic acid methylmalonic acid is pretty commonly used to assess for B12 status. Vitamin B6 is common in potatoes, bananas, and whole grains as well as meat, and you can get it in the form of pyridoxine or P5P. One of the things about P5P that you will hear is there is questions around how bioavailable it is, and it's uncertain absorption in the GI tract. So I think the jury's still out on that one. I tend to just use regular old pyridoxine because of that. Zinc, keep in mind, if you were carefully paying attention, zinc is a cofactor that's used in both the main methylation pathway and the backup methylation pathway. And so that makes it critical to methylation support, and it's a very common mineral insufficiency in our patients. So zinc, I cannot impress upon how important zinc is to the system. Now it does compete with copper, so you certainly don't want to be overdoing it with zinc, and that's where maybe a plasma evaluation, something like a zinc copper ratio, can tell you a lot of information. Lastly, choline and betaine. These provide additional methylation or methyl groups that can be used for that backup pathway. And clinically, it's been shown to be useful in metabolic syndrome and fatty liver, and in overall correcting the methylation abnormalities in the cell. So a wonderful therapy, I think, that we're going to start leaning on heavier and heavier. And if I don't want to supplement directly with choline or betaine, I might just think about soy lecithin. It is a very cheap supplement, and it's a pretty good source of not only phosphatidylcholine and betaine, but phosphatidylserine, inositol, all those great nutrients. So I think soy lecithin is a wonderful product. I discussed a little plug for glycine already, but it's been used in multiple conditions like anxiety, poor detoxification, and sleep quality. It indirectly supports methylation pathways, and it tastes very good as well. I think as a last resort, or for people who have very severe alterations in the methylation pathway, we could think about SAMe as a supplement. It is the main methyl donor, right? So my only concern is long-term use and potential for over-methylation. It's also very, very expensive, and the doses that were used in a lot of the literature were very high doses, like well beyond the amount that I think our average patient will care to be taking. And so that's my presentation. I know it leaves a few minutes for questions, and thank you all for listening.
Thanks so much, Dr. Chapman. That was a ton of information, and this information will be available to all the listeners. We do have a couple questions here. One was, do patients have to come off their supplements prior to testing, and if so, for how long?
Yeah, that's a great question. With the methylation panel, we are essentially leaving it up to the clinician. We are saying, it kind of depends on what you are wanting to see, doctor. If you want to see a patient's baseline levels of if you want to see a patient's baseline levels without supplementation, I would take them off. And since mostly we're talking about B vitamins, those are water soluble. They tend to wash out in hopefully 3 to 4 days. So, maybe to be safe, you could think about even having them come off for a week to get a baseline. Or if you're more interested in how well their supplementation is helping or not helping them, or do I want to see what they look like on their supplements, you could just leave them on, and we'll do the test either way. It kind of just depends on what you want to see.
Okay, thanks. What is the sample type being collected for testing?
Yeah, so since we're doing a biomarker analysis and a genetic analysis, it is a buccal swab for the genetic SNPs, and then it is a plasma blood draw for the biomarkers.
Okay, great. Are there any support materials being offered around helping with test interpretation or any sort of guidance?
Yeah, absolutely. So at Genova here, we offer complimentary medical education consults to go over any test report, and can be a 15, 30-minute report walkthrough. We can go over the case details, discuss the results, talk about what that means as far as clinical intervention. I think that's probably one of our best resources, especially if you're just getting new to methylation assessment. We can really kind of walk through in great detail with you the test as a whole and patient results. We're also putting out more and more content in the form of support guides, webinars, and things of that nature to assist in interpretation questions as well.
Okay. So there's a clinician who had a patient with an MTHFR SNP and hypertension. They started on methylated B vitamins, and after 2 weeks started to have chest pain, spike in blood pressure, flu-like symptoms. Is this an expected side effect? What are your thoughts on that scenario?
It's hard to track those particular symptoms down to one individual thing, of course, right? That's not a symptom picture that I have commonly seen with that supplementation. I mean, obviously, when you hear things like chest pain, you're doing, first and foremost, you're doing due diligence to rule out any sort of severe event. But all in all, those are not things that I have commonly seen with that particular supplementation. But as mentioned, we don't have a lot of literature yet on what happens if somebody has an over supplementation of any particular form. So, I think that's an area that's a little bit unknown, but just from my clinical experience, I don't know if I would directly correlate those things.
Okay. And then another question, how do methylation issues relate to obesity?
Well, yeah, if you go back to one of the earlier slides, we're starting to learn that both high homocysteine, we know that high homocysteine and high SAW are significantly strongly correlated with obesity issues, metabolic syndrome, cardiovascular disease. But one of the other things that we're starting to see as well is that high SAM levels might also be associated with those particular things. And so I think we're going to learn more and more that not only does SAW and homocysteine play a role, but high SAM may also be overwhelming the system and causing a potential even more genetic and epigenetic modification that puts the patient at risk. So I think a little bit stay tuned, but also the first thing I'm thinking is high homocysteine and high SAW for those conditions.
Yeah, great. All right, well, that brings us right up to the top of the hour. I want to thank everybody for listening in today. Thank you, Dr. Chapman, for all the work that you did in preparing this and teaching us some really valuable information.
Great, my pleasure. Thank you so much for joining.
Bye, everyone.